Bismillahirrahmanirrahim. Assalamu alaikum. Good morning, good afternoon, good evening, everyone. I welcome you all to today's webinar, which is on the clinical management of dengue in Pakistan, challenges and strategies. I am Dr. Masab Umair. I'm working as a senior scientific officer and in charge of virology department at NIH. Before we begin this session, there are some housekeeping rules. So this webinar is going to be recorded and the recording will be available at our YouTube channel, Viral Insights. We would like this to be an interactive and an engaging webinar. So we encourage that if you have any questions, you can post them in the chat box and we will take these questions later on. So it's an honor for me to introduce Professor Dr. Nasim Akhtar. Professor Dr. Nasim Akhtar is a well-renowned infectious disease specialist. She's working as an head of Department of Infectious Diseases at Pakistan Institute of Medical Sciences. And she has extensive experience in management of infectious disease in Pakistan. She is also a member of several professional bodies such as IDSP and International Disease Society of Pakistan. So Professor Dr. Nasim Akhtar, welcome. Without further ado, I would request you to please start your presentation. Thank you.
Thank you very much, Dr. Masab. And I will take the opportunity to discuss dengue clinical case management. And as you know that Pakistan is facing a huge challenge of managing dengue cases, and there is always a surge of dengue cases every year, starting from the end of the September, then October, and then it usually ends by the mid or end of November most of the time. And we see a large number of cases being hospitalized every time, in which poses a huge burden not only on the hospital as well as on the economy of the country. And as we know that this is a preventable disease which can be managed with the effective measures. So I would briefly be giving my overview of the talk that what is dengue virus, how it is transmitted, what is its epidemiology, what are the clinical features, signs and symptoms, and how to investigate a case of dengue, and what is appropriate management, followed by some of the challenges and way forward. So all we know that there are four dengue virus types, starting from 1 to 4, and all of these strains, they can cause disease. And there is a lifelong immunity which is imposed by any dengue viral illness. And it means that if you suffer with a dengue virus with type 1, you will be protected from this virus in the subsequent episodes. So there is also a short-term cross immunity, but it is very, limited, and it does not, protect you from the other strains. So sequential infections that are occurring in the people, they put them at greater risk of severe dengue, and this is basically because of the antibody-dependent enhancement. Then there are genetic variations as well in dengue virus types, and some of the variants, they may be resulting in the lethal disease as well. So we know that dengue virus is a vector-borne disease, and it basically occurs because of the virus present in the saliva of the infected Aedes species mosquito. There are other methods of transmission of the dengue virus as well, like perinatal or vertical transmission, that is mother-to-child transmission. And some of the cases has also been reported with blood transfusion or organ transplantation. Very little is known about the needle stick injuries or mucocutaneous route of the transmission, but some of the nosocomial transmission of the infection has been reported. And it's very, very rare to have the transmission of the virus via breast milk. This is, you can see the picture of the Aedes aegypti mosquito. There are two species of the mosquitoes which are basically responsible for transmission of the dengue virus. And these are Aedes aegypti and Aedes albopictus. And these are prevalent in Pakistan. And this is the picture of Aedes aegypti. You can see that here in the left side of the image is the male mosquito, and in the center and the right side is a female mosquito. The female mosquito is slightly, larger in size as compared to the male. And the second mosquito species is Aedes albopictus. It is also known as Asian tiger mosquito because of the fact that it has stripes just like a tiger on its body. And the word albo means white and pictus means painted. It means it is a white painted mosquito, and it is quite visible from its appearance as well. And this is the photograph of the Aedes albopictus, as you can see. And this is the picture of Aedes albopictus when it has taken a blood meal, and you can see the blood visible in its tummy. There are few differences between albopictus and Aedes aegypti, and it's very hard to differentiate them by looking on them. But once you see under the microscope, you can see, or with the hand lens, even you can see some of the differences between them. So you can see that Aedes aegypti, which is the most common virus, most common species of the mosquito, which is responsible for transmission of the dengue virus, it is brown in color, whereas Aedes albopictus is black in color. You can see that this mosquito, which is Aedes aegypti, it has head, thorax, and then abdomen. And you can see that there are characteristic stripes on its thorax. And here you can see it is just like the strings of violin. And there are 4 lines, 2 are more darker or white in color, and the 2 which are in the center, they are thinner. And they are just like the strings of a violin. So, and another mosquito which you can see here is the Aedes albopictus. And there is a large, thick, big line which is present just in the center of the thorax. So there are certain other features which I'm not going into the details, but by the color, if it is brown and having 4 stripes on its thorax, it is Aedes aegypti. And if it is black in color and having single stripe on the thorax and which is thicker, it is commonly Aedes albopictus. So basically, Aedes aegypti mosquito is also known as, causing yellow fever virus, but it can transmit other viruses as well, like dengue virus, chikungunya virus, Zika virus, and Mauro virus. While Aedes albopictus can transmit dengue virus, chikungunya virus, and Zika virus. And it is very important to mention over here that only the female mosquito requires blood meal for maturation of the eggs, and male mosquitoes, they usually live on the fruits. Mosquito is basically attracted to various chemical compounds which are emitted from the mammals, and these include ammonia, carbon dioxide, lactic acid, and octinol. And it has been observed in various studies that the female mosquitoes, they have specific receptors on the basis of which they are attracted towards certain chemicals in the human bodies, and therefore they bite them and they are attracted towards them. A mosquito can transmit dengue virus as little as 100 virus particles per secretion. So you can imagine that how many viruses can be transmitted per bite. So mosquito remains infected throughout the life, and the disease, it's basically a vector transmitting the disease. Here you can see that how the transmission of dengue virus occurs. It is not a contagious disease. It cannot be transmitted from person to person because it's a vector-borne disease, and it only needs a vector, that is a mosquito, for the transmission of the virus. And the mosquitoes can carry the virus from a viremic person only when the person is febrile and having high viral load in the body. So here you can see that this boy is, febrile and is viremic. And from here, the mosquito bites and carries the virus in its saliva. And there is an extrinsic incubation period in the body of the mosquito. It takes about 8 to 12 days. And after that, dengue infected mosquito can bite another person who is normal and healthy and can transmit the virus to that, gives dengue virus to this girl, as you can see in this slide. And then there is an intrinsic incubation period in the normal host on which the mosquito has bitten, and it takes another 2 weeks for the symptoms to be developed in the individual who has bitten by the virus-containing species of the mosquito. So girl now can pass dengue virus to another mosquito if bitten while she is viremic. So it's very important to know that only when the patient is viremic, the mosquito can carry the virus from them, and it can transmit the virus to others. So here comes the concept of putting the patients in the nets, and it is especially useful when the patient is viremic. Here you can see that 2024 global burden of the dengue, and more than 10 million cases have been reported worldwide. And there are about 103 countries or territories who are reporting cases in all 6 WHO regions. And more than 20 countries have reported outbreaks, including America. So few slides on the dengue in Pakistan. You can see that from this slide, the first case of dengue virus is confirmed from Pakistan in 1994, and both Den 1 and Den 2 were held responsible for that. Second outbreak was reported from Karachi in 2005, and it was basically because of the dengue virus 3. Larger outbreaks, as you can see from this graphical representation, they have occurred from time to time, and the major outbreak was in 2019 as well. And some of the data which I have picked up from some of the resources from Pakistan, by September 2024, Pakistan had reported 2,795 new cases, with Balochistan being the hardest hit region. And by 12th October 2024, Punjab reported more than 3,000 cases. And this is the slide which shows that almost all strains of the dengue virus are prevalent in Pakistan. And this slide shows the data by NIH, and it also shows that the major type of the dengue virus, which was isolated from January to October 2024, was dengue virus 2, whereas a few of the cases were reported through dengue virus 1. So this slide also shows the month-wise surge in the number of the cases of dengue infection in 2024, and the majority of the cases you can see are seen in October 2024. This is some of the data from the district Islamabad, and here you can see, and this data is also from January to November 2024, and total patients in Islamabad were recorded to be more than 3,000. So as far as the clinical course of dengue is concerned, the infection incidence is 5% per year, and majority of the patients, they remain asymptomatic. About 75% patients, even if they acquire the disease, they are asymptomatic. Only 25% cases develop the symptoms, and among these, 95 to 99% cases are those who develop dengue, and very small percentage of the patients, they end up with severe dengue, and it is 1 to 5%. And again, it's very important to understand that mortality rate is very, very low. Majority of the patients, they do survive, and very few people who have comorbidities or any risk factors, they usually die. And again, it is in the range of 0.5 to 5%. So dengue fever is also known as breakbone fever. It's a severe flu-like illness. And, it's called breakbone fever because it causes severe body aches and pains, especially retroorbital pains, severe headache, severe backache. And, the patients usually tell that they have not experienced such kind of severe body pain with any other illness other than, dengue. Clinical features of dengue, they can be variable according to the age of the patient. Young children and elderly, they may have more severe symptoms as compared to the younger individuals. And there are different types of dengue fever. Second important thing which I want to highlight is that we label the patient having been in dengue hemorrhagic fever phase. So what is dengue hemorrhagic fever? It's a misnomer, I would say. Hallmark of dengue hemorrhagic fever is basically the plasma leakage. And it does not mean that the patient is having some hemorrhage. It is the plasma leakage, which is basically showing us that the patient is in this phase. This is basically because of the leakage of the fluid from the intravascular space to the extravascular compartments. And it is basically because of endothelial dysfunction. And the patient have the tendency to bleed. Sometimes, the bleed is severe, but in most of the cases, bleeding is not a common phenomenon. And dengue shock syndrome is the severest form of the dengue hemorrhagic fever. And some of the patients, they may have extensive plasma leakage, which can end up with hemodynamic compromise, and patient can end up with shock. And basically, I would say that there's the mismanagement of a case of dengue fever that ends up with dengue shock syndrome. Another entity is called extended dengue syndrome. And, in this case, there is basically organ involvement, and organ failure can occur. Multiple organs can be involved, like, liver injury, renal injury. Sometimes patient can have, dengue encephalitis and end up with, severe complications. And usually people who are having comorbidities and co-infection, they are at risk of developing extended dengue syndrome. So this slide is very, very important, and borrowed from the WHO guidelines. And here you can see that what are the patients who are having warning signs and what are the criteria for severe dengue. It's very, very important to know that initially the patient usually present with minor symptoms, and the patients are labeled as having dengue are those who are basically living in an area which is endemic for dengue. And that Pakistan is a country which is endemic in dengue infection. And here, if the patient belongs to an area where dengue is prevalent and patient have fever and any of the following criteria like nausea, vomiting, rash, body aches and pains, and if the tourniquet test is positive, patient have leukopenia or any of the warning signs, we can label the patient as having dengue. And what are the important warning signs? They should be always kept in mind, like severe abdominal pain or tenderness. Patient can have persistent vomiting, which is not controllable. Patient can have mucosal bleeding. Patient is restless, lethargic. There is liver enlargement, and there is laboratory evidence of rise in hematocrit and fall in platelet count. And what are the criteria for the severe dengue? Patient can have severe plasma leakage, which can lead to, donkey shock syndrome, fluid accumulation. If there is an, rise in the transaminases level more than 1,000, patient have impaired consciousness, and there is involvement of heart and other organs. So this slide is very, very important while, assessing the patient with a dengue fever. There are three phases: febrile phase, critical phase, and recovery phase. And in febrile phase, the patient has a fever which lasts for 2 to 7 days. Sometimes we have seen that patient can end up having a prolonged febrile phase, which can be 10 days or maybe more than that. And usually defervescence occurs on day 3 or day 8 of illness. And this is a time where, when defervescence occurs, the word defervescence means that patient has become afebrile. So whenever a patient with dengue comes, once the fever has settled, I would say that patient has ended with the febrile phase. And now this is a phase where the patient needs critical monitoring or close monitoring, because this is the stage where either the patient will improve and or the patient will end up with warning signs. So monitoring is very, very important. So what is critical phase? Again, I would say that this is a misnomer. It's not actually the critical phase. I would say most of the patient, when I tell them that you are in critical phase, they become afraid that they are having some complication. But I would say the critical phase means that patient is not critical, but the patient has entered a critical phase, which needs more, extensive, close monitoring and, keeping an eye on the warning signs. So what happens in critical phase? There is drop in platelet count with rise in hematocrit. What does it mean? It means that plasma leakage has occurred and probably the patient is having hemoconcentration and patient is not taking enough fluids. So platelets would drop and hematocrit would rise. So usually leukopenia appears 24 hours before the appearance of drop in platelet count. And this is also very, very important clinically. You can monitor the response later on, because at the end of, the dengue febrile state, once the patient recovers, white cells recover earlier and then platelets start rising. So this is about critical phase. And these are the warning signs which we should be looking for during the critical phase. So then last phase is recovery phase, and there is gradual reabsorption of the fluid which has leaked from the vessels, and it usually lasts for 48 to 72 hours. Patient then feels generally well. There is hemodynamic status which becomes stabilized, and patient starts passing enough urine. So what happens is laboratory findings, hematocrit stabilizes or it may decrease because now there is fluid reabsorption which is happening during this phase, and white cell count, it starts to rise, followed by the rise in the platelet count. So what are the problems which appear in three phases? And during febrile phase, patient can end up with dehydration, fits, or sometimes neurological disturbance. And in critical phase, patient can develop extensive plasma leakage, which can appear in the form of pleural effusion or ascites, and patient can develop edema, patient can have severe hemorrhage and organ impairment. Sometimes patient may end up with sepsis or superadded bacterial infections. And in recovery phase, what are the problems? Because this is the reabsorption phase, patient can end up with hypervolemia and acute pulmonary edema can develop. And we have to be very, very careful during the recovery phase because we have to reduce the fluid intake, especially the IV fluids should be reduced, and patient should be encouraged to take, orally. So what are the risk factors for severe dengue? Infants who are born to seropositive mothers, elderly patients, especially after the age of 65, those who are having comorbid conditions like having some hemodynamic instability or having some hematological disorders like patient having sickle cell disease, thalassemia, hemoglobinopathies. If patient is extremely obese, patient is diabetic, hypertensive, have some respiratory illnesses and cardiac failure, etc. And it is always mentioned that the second time if somebody gets infection, it's more severe as compared to the first infection. So what happens, what are the factors which are responsible for death in dengue? It can be due to fluid overload. Sometimes it is unrecognized disease which leads to prolonged shock, unrecognized hemorrhage which has already taken place, and patient is having co-infection or septicemia. So some of my slides would focus on assessment of the patients because it is very, very important for the clinicians. So we must know what is pulse pressure. It is systolic blood pressure minus diastolic blood pressure. And what is narrow pulse pressure? If the difference between systolic and diastolic blood pressure is less than 20 millimeter of mercury, it means it's a narrow pulse pressure. And it's very, very important. From this slide, you can see that what is happening. On the left side, you can see that this is a blood pressure which is normal, 120 by 80, and gradually you can see that the difference between systolic and diastolic blood pressure has become narrowed. So heart rate keeps on increasing and pulse pressure becomes narrow. It means the patient has, going from a state of compensated shock to a decompensated shock. And this is a timeline where we have to, be critical and have to manage the patient very judiciously with the justified use of fluids at that time. So how to identify plasma leakage? You can look for ascites, you can look for hemoconcentration by looking at hematocrit levels. Patient can have hypoalbuminemia or, proteinemia. And you have to monitor few things like hematocrit is very, very important, and the platelet count is very important. So during critical phase, we have to look on hematocrit and vital signs, and it should be looked upon very, frequently, like every 1 to 2 hours, and fluids should be adjusted accordingly. If there is increase in hematocrit and fall in platelet count, it means that patient is having, signs of hemoconcentration, and probably the patient is having, dehydration. And the decrease in platelet count it always corresponds with the plasma leakage. And reduced urine output, narrow pulse pressure, tachycardia all indicate that patient is going towards decompensated shock. So this is very, very important to have a record of the all vital parameters in the sheet of the patients while the patient is admitted. And you can see from here that blood pressure, temperature, pulse rate, respiratory rate, hematocrit, and then intake output record is, kept quite cautiously because the management for the dengue fever or its complication is based on judicious use of fluids only. So hemoconcentration, how do we define hemoconcentration? This is very, very important for the clinicians. If there is a 20% rise in the hematocrit, it shows hemoconcentration. And if there is a 20% fall in the hematocrit level, it shows that if there is a drop in hematocrit because of excessive fluid intake or it is because of the fluid overload. So we should be very wise enough to know that what is the hematocrit at baseline, and we have to monitor the hematocrit from the baseline, not from the daily hematocrit levels. You have a baseline hematocrit and see whether there is 20% rise or 20% fall in the hematocrit to assess the patient. So overall assessment includes assessment of mental status, hydration status, hemodynamic status, look for plasma leakage, and then examine for rash and any bleeding manifestations like in the form of mucosal bleed or blood in urine, etc., or petechial hemorrhages. Another important thing which I want to mention over here is the tourniquet test. And this is also very important. And by this, you can see that whether the patient is have bleeding tendency or not. So there are different rashes which can appear in dengue. And during febrile phase, you can see that there is a maculopapular rash which appears on the skin. And then you can see that this rash is similar to the first, which I've shown on the back of the trunk. And it is blanchable rash. Like it leaves a mark on it on the body if you press it. And then petechial rashes can appear on the body in the extremities. And later on, after defervescence, you can see that it has become more confluent and there are islands of normal skin in between. And you can see that when there is severe dengue, it can end up with severe GI bleeding, which is associated with prolonged shock, etc. Then normal laboratory findings, you all know. And in dengue fever, there is a drop in white cell count. there is drop in platelet count, hematocrit would increase. And this slide is very, very important because the most diagnostic investigation is the non-structural 1 protein in the blood. And you can order this test, which is called dengue NS1, during first 5 days of illness. And after 5 to 7 days of illness, IgM levels, they start to rise and they continue to be present for at least 90 days. And in between, the IgG levels, they start rising. So for diagnostic purposes, earlier on, dengue NS1 is very good. And after the 5 days, IgM levels can be very, very helpful. So overall assessment includes, does the patient requires admission or not? Which phase of the dengue the patient is in? Are there any warning signs? What is the hemodynamic status? And we all know that WHO has published very good guidelines for the management of the dengue patients, and you can have a pocket guideline by the WHO for all algorithms. Coexisting conditions are very, very important, like patient in pregnancy, infancy, and those with having comorbids, they should be hospitalized. And if the patient is living far away from the hospital, they should also be hospitalized. So what could be our discharge criteria? If the patient is afebrile for 48 hours, there is improvement in the clinical status, like patient is able to take orally, there is enough urine output, no respiratory distress, and there is rise in the platelet count, and patient is having a stable hematocrit. So important point is that IV fluids required are only for the short period of time. Even the patients who develop shock, there is need to adjust fluids very rapidly to respond to patient's condition. Narrow pulse pressure is an indication for more aggressive intervention. Close monitoring and recording of intake output is very, very important. And tachycardia is a very important sign. If fever is not there and tachycardia is there, it means that your patient is heading towards shock. And all the history which I have already mentioned is very, very important. So we all know that dengue is a viral illness which does not have any treatment. No cure is there. Standard supportive care is very, very important. It can be fatal if proper fluid has not been given and warning signs have been missed. And appropriate use and timing of transfusion is very, very important. Usually blood and blood products are not needed in the management of dengue fever, even if the platelet counts, they drop very low. And we have observed that during the previous 1 or 2 outbreaks, very few patients needed platelets. And these platelets are transfused only if the platelet count has gone very low, usually less than 10,000, if there are some risks of bleeding present with that. So avoidance, recognition, and management of fluid overload is also very, very important. So there are 3 groups of the patients who need to be managed. Group A are those patients who are stable enough to be sent home, but one should have a careful eye on the platelet count and hematocrit, and they should be advised to take plenty of fluids and keep an eye on the urine output. And the group B patients are those who need hospital management, and group C are those who need emergency management. So this is the flow chart which show that if patient is not having warning signs, the patient is in group A. And if the patient is having, comorbid conditions and patient is not able to tolerate orally, they are having comorbid conditions, they fall in group B category. And patients who are having shock, plasma leakage, severe plasma leakage, and significant bleeding, severe organ impairment, and rise in transaminases, these are the patients who need quite extensive care, and they should be hospitalized and managed in the HDUs. So I'm not going into the details of those patients who are sent home, but especially those patients who are with warning signs and coexisting condition, they need, good management. So what is important for their management? Obtain a reference hematocrit, then give only the isotonic solution. And what are those isotonic solutions? These are normal saline and Ringer's lactate, and start fluids and then reduce the rate after 1 to 2 hours. And then after another 2 to 24 hours, reassess the patients and then see that what is the need for further IV fluid therapy. So if the hematocrit remains the same or rises, then reduce the rate for 2 to 4 hours and then reassess. So it means that you have to assess the patient every 2 hours and then you need to adjust the fluid intake. So this slide is basically showing that if the patient is able to tolerate fluid, give them oral fluids. If not able to tolerate the fluid, then give them maintenance fluid plus additional fluids to them. So usually we transfuse about 100 to 120 cc of the normal saline per hour. And this is, general guidance for all the patients, adult patients who present to us with the dengue fever or in the dengue hemorrhagic fever. If the patient is in the critical phase, then you have to give the fluid at a rate of 7 ml per kg per hour at the peak of the leakage, and then you have to decrease the fluid as quickly as possible. And if the patient is in shock, then high rate of infusion would be required, like 20 ml per kg per hour of the fluid, and then decrease the rate immediately to 10 ml per kg per hour when the BP is restored. So this is the general guidance, and this is very easy to remember that if patient is not in shock, give fluids at a rate of 7 ml per kg per hour. If the patient is in shock, then give high rate of the infusion like 20 ml per kg per hour, and then reduce it after 1 to 2 hours. So you have to assess the patient each time after every 1 to 2 hours to manage the complications. So provide minimum adequate amount to restore intravascular volume, use blood products very consciously, monitor for fluid overload, and keep on examining the patient and see that if there are any signs of fluid response, like normalizing hematocrit. And you can see that if there is increase in urine output and pulse pressure has become normal and there is reduced tachycardia, it means that you have to reduce the fluid intake. So this is again the same thing which I have already explained, and I'm not going into the details of all that. These are the flow charts which WHO has provided, in which algorithms are provided for the management of compensated shock and then decompensated shock. And you can see that, as I have already mentioned, then you always start with 5 to 10 ml per kg per hour of the fluid, and then check for the hematocrit. If the hematocrit is rising, you can increase the fluid to 10 to 20 ml per kg per hour for another 1 hour. And if patient has improved, then you can reduce the fluid to 7 to 10 ml per kg per hour. So this is the algorithm in case of, if the patient is having compensated shock. But if the patient is having decompensated shock, here you can see that you have to give the high amount of the volume, that is 20 ml per kg fluid per hour. But initially you have to, give boluses of the fluid, at least 3 boluses of the fluid should be given, and they should be 10 to 20 ml per kg per hour. And then after that, if patient has improved, you can immediately reduce the fluid intake to 10 ml per kg per hour for the next 1 hour. And if there is further improvement, then you can further reduce the fluids to 2 to 3 ml per kg per hour in the next 2 to 4 hours. So this is basically the good practice, that you have to assess the patient quite frequently after every 1 to 2 hours if the patient is having severe dengue. So some are contraindications, like steroids are contraindicated in dengue, and similarly non-steroidal anti-inflammatory drugs like brufen, ibuprofen, disprin, and blood thinners, they are contraindicated. And if there are some specific need for that, one must consult with the primary physician for that. So we have to look for the complications during shock, like acidosis, bleeding, and what is calcium level, what is sugar level, and if hematocrit is reducing. And cross-match should be available for the blood transfusion if it is required. And we can transfuse whole blood if the patient is in shock. So very important take-home message is that the prophylactic use of platelets is not required, and it should only be used whenever we see that patient is having bleeding tendency and patient is having overt bleeding, like patient is having bleeding. So indications for transfusion are that red blood cells are the first line for bleeding. If not available, may use whole blood. And indications are that if there is hematocrit less than 10%, there is massive hemorrhage, or hematocrit no change with significant plasma leakage. So whole blood can be transfused. Platelets and FFPs are not recommended for treatment of severe bleeding, and may consider if the platelet count is less than 10,000. This is very, very important, because we have to reduce the burden on the blood banks as well, because this sort of transfusions are not needed. So if there is some fluid overload, we should consider using plasma expander or dextran, and administer colloid in place of the isotonic fluids. If patient is having ongoing shock, we can give colloid plus furosemide, And what are the colloid? Colloid are the plasma expanders in the form of dextrans. And these are available in some of the hospitals and are not available everywhere. And along with that, we can give furosemide at the rate of 1 ml per kg per dose and continue with dextran. So this is a case where you cannot administer more fluids and patient is going into the shock. And similarly, when to discharge the patient, when plasma leakage typically, has stopped, it takes only 72 hours. And after that, if there is rise in platelet count and there is stability in the, hematocrit and urine output is adequate, one can always think of discharging the patient. So very important thing is how can we prepare for increasing dengue cases in Pakistan? And this is a major challenge for us. And we know that the dengue breeding places are everywhere. And we know that how dengue spreads. Basically, these Aedes species of mosquito, they breed in the places where water is stagnant. And usually it is considered that it is a disease of the clean water. But we know that we, dump different, equipment like tires and junk everywhere in the houses and in the outside and the workshops where the dengue mosquitoes, they breed quite effectively, and in stagnant water they release their larvae which they grow up into the adult mosquitoes. So taking care of the breeding places for the mosquito are very, very important. They should be controlled, they should be covered. And what are the novel strategies which can be managed or used to control the dengue spread in Pakistan? So there are some emerging tools like novel vector control strategies. They are under review. And then dengue vaccines. One of the vaccine is called Dengvaxia, which is recommended in USA. And it is recommended for children of 9 to 16 years of age with previous dengue virus infection and those patients who are living in the endemic areas. And then there are some other vaccines like TAC-003, which is licensed in several countries. And there are some other vaccines which are under trial. Then what is important to prepare for increasing dengue cases? Number one, we should recognize dengue is there in our clinical practice. What are the warning signs? Early recognition of the dengue patients is very, very important. Test appropriately for dengue. Unnecessary tests are not required. No specific antiviral treatment is available. So the standard of care is the fluid management. We must know that what are the early warning signs for the admission. And prevention and control, I would say, is the main thing. And it is a major challenge for a country like Pakistan, where the disease is endemic, where infection prevention and control measures in the community as well as in other areas are not quite good. Mosquitoes that spread dengue, they are quite active during the day. And we must not get out of the houses unnecessarily if it is not needed, and should avoid going outside in dawn and dusk. And especially we should wear the full sleeves, and we should lower the risk of getting dengue by protecting ourselves from the mosquito bites by clothes that fully cover the body. And mosquito nets should be applied while sleeping. Window screens can be used, and there are mosquito repellents which can be applied like DEET and picaridine, or there are some other chemicals which are helpful. Coils and vapors can be used. And similarly, mosquito breeding can be prevented by, preventing the mosquitoes from accessing egg-laying habitats, disposing the solid waste properly, covering and applying appropriate insecticides to the outdoor water storage containers. And then we should follow and adhere to the WHO pocket guidelines for the management of the dengue patients. Similarly, some vector control measures are in place and research is going on, like the use of Wolbachia as well as genetically modified mosquitoes, which is an area of the research. And Pakistan should also adopt simple measures and then should go towards the novel measures for the prevention of dengue in Pakistan. So thank you very much. So if there are any questions, I'm there to.
Thank you so much, Madam. It was indeed very informative and a very comprehensive presentation. You have discussed the clinical aspects of dengue patients, as well as you mentioned about the management of these patients. And in the last part of your discussion, you also highlighted some of the prevention and control measures that can be taken. So there are a few questions in the chat box. And so the first question for you is that what are the factors contributing to the increasing incidence and severity of dengue fever outbreaks in Pakistan? And how do regional variations in climate, mosquito vector control measures, and healthcare infrastructure impact patient outcomes?
Yeah, thank you very much. Very important question. I would say, as we know that Pakistan is a country where there is frequent changes in the climate, and it's a tropical country, and dengue is prevalent in tropical and subtropical areas, and especially when the floods occur and when there is monsoon season appears, there is stagnation of water. And we have noticed that whenever the monsoon rains happen, there is increase in surge of the cases of dengue fever in Pakistan, and we do not have adequate measures for control of dengue breeding places. So awareness and knowledge is also very important. Although we have seen that there is some improvement in that, but still we see that there is huge rise of cases every year. And then preventive measures are being taken by the government, and they do use larvicidal activity. They start larvicidal activity quite a few months before the dengue outbreak season happens. But at the same time, more effective measures are needed for that, like awareness, um, uh, protective measures which are very simple. And similarly, awareness, creating awareness among the masses is very important. And I think we all have to join hands together to adequately control the spread of the dengue. But it's going rampant and it's going out of hands, as we have seen it in the last few years.
Thank you. There is another question. We have seen serotype shift and more severe cases in 2024, in which dengue 2 was dominant as compared to dengue 1 in 2023. How is this situation? How this situation will be managed clinically, and how can we prepare?
Thank you very much. Very important question. We have seen that although there is some change in the prevalence of the dengue serotypes, and this is quite expected. If a population where the dengue is endemic, if the population has got infection with one serotype, next time there will be protection from that serotype, and the person has a chance of having dengue with other viruses strains like dengue. If dengue 1 was the first virus to cause the dengue, then patient can have a chance of having infection with dengue 2, dengue 3, or dengue 4. So, but we have not seen much of the difference in the clinical severity of the illness in different strains. So the clinical signs and symptoms and the severity remains almost the same, and there has not been observed any difference in the management protocols or severity or outcomes, and the mortality remains very low.
Okay, I think you have answered this next question partially. So here is one more question. How do different dengue serotypes influence the severity of subsequent infections? And what implications does this have for vaccine development?
Yes, very good question. As I have already mentioned, somebody who gets infection with one serotypes, patient develops, protection from that in subsequent episodes. But at the same time, it has also been noted that there is a mechanism which is called antibody dependent enhancement in the immune system. So that is the reason that the second episode of dengue can be more severe as compared to the previous episode. So that it's therefore very important that we should focus on prevention of this vector-borne disease rather than on focusing on the treatment. And the different dengue vaccines are available, and there are 4 or 5 types of dengue vaccines which are under the research. But some of the vaccines cannot be used in those patients who have not suffered from the dengue previously. So Dengvaxia is the one where it has been advocated for use in those who suffered from dengue previously. So, and the timeline for use is from 9 to 16 years. And there are some other vaccines which are under research, which can be used in elder population as well.
Thank you. I have a couple of questions, Madam, for you. You being, a well-known expert of infectious diseases, and since you are working in one of the major tertiary care hospitals of Pakistan, so have you seen during the current outbreak any differences in clinical signs and symptoms of patients that have presented to PIMS? And my second question is, have you noticed any disease, severity in primary infections?
So, PIMS is a tertiary care hospital, and we receive a huge number of the patients every year with the dengue. And majority of the patients, they are admitted with either dengue hemorrhagic fever, that is DHF with plasma leakage. And very rarely the patient, they end up with shock. So majority of the patients which we saw, they were in DHF phase and they improved, and we did not observe any mortality during this year. And the patients who develop severity of the illness are those who are having risk factors, as I've already mentioned, those who are elderly, pregnant ladies, and similarly those with comorbid conditions, they were having more severe illness. Like the drop in platelet count was very sheer. Most of the patients who were sick enough, they had a platelet count in the range of 2,000 to 10,000. But only few patients, they needed platelet transfusion, and there were very few patients who ended up with shock, and they were managed quite effectively. And we did not observe any mortality with that. So we saw that the drop in platelet count was more pronounced, and at the same time, liver enzymes were deranged in almost all of the cases who were hospitalized.
Thanks. One more question. What are some of the critical steps that clinicians or healthcare facilities they can take to manage or improve severe dengue cases, especially in resource-limited settings? Because you being working at PIMS, which is one of the major tertiary care hospitals and is a well-resourced hospital. So, what is your thought on that?
Yeah, thank you very much. I think clinicians have to play a major role in that. And the main objective of today's talk was also to apprise the clinician that when to suspect a case having dengue fever. So you know that there are various viral diseases which are having similar manifestations, like dengue fever, chikungunya. Then you can see rare infections like Zika virus infection, malaria, typhoid. All of these patients who are having suffering from these diseases, they have almost similar clinical presentation, and that is high grade fever. There are some minute differences on the basis of which clinician can diagnose the case earlier on. Like in dengue fever, as I already mentioned, patient have complaints of having severe body aches, severe retroorbital pains, severe headache, and it's called breakbone fever, and arthralgias and myalgias. These are the earlier signs. And in chikungunya, most of the patients, they present with severe joint pains and they have arthritis rather than arthralgias. Large joints, small joints of the hands, and backache is very, very common in, chikungunya. Otherwise, both of these viral illnesses are almost similar. Similarly, if there is prolonged illness, like patient is having more GI symptom as compared to the other symptoms, and there is more malaise and prolonged symptoms, then typhoid should be considered. But I would say that we must have a high index of suspicion, especially some outbreak is going on, and we must order investigations, very simple tests, like you can order blood complete picture looking for white cell and platelet count, hematocrit, and similarly, we can advise having other tests, which is called dengue NS1. As I have mentioned, it is a very good test for diagnosing dengue and ruling out other diseases. And similarly, malaria and dengue can coexist. So tests for malaria should always be ordered because mosquito, are having different, different populations. So it's quite possible Anopheles mosquito are also there in the population and can end up with having malaria and dengue together. And then warning signs are very important for the clinicians. They should keep an eye on the warning signs and should follow the criteria for admission and when to discharge.
Pakistan, we all know it's an endemic for many viral diseases, and dengue it is a major public health concern. So, looking at the disease burden and looking at different outbreaks, almost we are facing every year. What are your recommendations in terms of vaccine? So first of all, is there any dengue vaccine available in Pakistan? And if not, what will be your recommendations? Should the health authorities consider it in the future?
Right now, no vaccine is available in Pakistan, and I would say that a country where resources are quite limited, we should be focusing more on the preventive aspect of the disease. And majority of the diseases in Pakistan, which we face on day-to-day basis, are all I would say preventable diseases. And vector-borne diseases, especially like dengue fever infection, it's quite preventable disease. And the simple measures are very, very important. I think vector control is very important, and awareness about modes of transmission and spread are very, very important. Public should know that they should take proper measures, and especially during the outbreak seasons, they have to use mosquito repellents, they have to use nets, they have to keep the areas clean. They should not keep the water stagnant in different areas in the house in buckets, and they should regularly or frequently clean the water supplies, especially in the water tanks. And these are the simple measures which are very, very important. And as far as the recommendation for the vaccine is concerned, I think every country should focus on vaccine availability, but keeping in mind the resource limitations. Obviously, first we have to focus on the preventable measures, and then we can always we must always work towards procurement of all vaccine preventable diseases in the future.
I'm extremely grateful to you, madam, for taking your time out. This is the second time you have joined us, and I'm again, extremely thankful. I would like to thank all the participants for joining us, and hopefully in future we will be bringing same sessions. Thank you, everyone. Take care.